I don't think I am ready personally to use that for all my patients.
Before we move away from the neoadjuvant setting, let me ask you another topic that has come up quite a bit, and that is the sense of an adaptive approach.
Okay.
And certainly there are trials that are testing an adaptive approach, and this was not necessarily the design of Destiny Breast 11, but I think you and I both get asked whether or not we're going to try to start off with THP, image, and then go to TDXD, or vice versa, TDXD, image, and then go to THP. We have to be careful because the trial, Destiny Breast 11, was not designed to answer that specific question. But how do you counsel colleagues who are asking you about a potentially adaptive approach in the neoadjuvant setting?
Yeah, it's such an important question, and I think it's certainly something that we want to explore further and understand the implications of further. I would say we have trials looking at that. We have trials such as Compass HER2, which gave THP and then decided based on residual disease to allow you to do more therapy, to allow you to do interventional therapy, which was in addition to TDM1, to Tucatinib, as well as a combination. Outside of the clinical trials, while it's very tempting and while I want to continue to optimize management for our patients and give them as little as possible to derive the most benefit, I think we have to take a step back and caution ourselves with multiple things that we need to think about, right? I think we have all appreciated that, yes, PCR can translate into long-term outcomes, but we've also appreciated the fact that not all PCRs are the same. The second point that I would make is when we think about the THP-based regimens and we think about what kind of PCR rates we achieve, I think THP-based regimens have given up 43% of PCR rates. So certainly with the TDXD followed by THP approach in DB11, we have gotten PCR rates of 67%. We've gotten a higher HR positive PCR rate. We've gotten 83% with HR negative PCR rate. So the point I'm making is I would love to have a biomarker, whether it's a clinical imaging biomarker, whether it's newer genomic assays such as HER2-DX that are being explored as well in many trials, which have prognostic implications, have not necessarily proven predictive implications. I would love to understand maybe if ctDNA or molecular residual disease assays can be utilized to further optimize a way of identifying the right patients. We have examples like the FORGAIN trial, which looked at FDG PET as well. I don't think I am ready personally to use that for all my patients to try and spare them 4 cycles of TDXD that DB11 give. I think 4 cycles are manageable. The safety profile is great. The efficacy is wonderful. Unless I have very robust data of who I could really pick out very comfortably to avoid this for, my question is, why should I not do this? Because it's giving me good efficacy, decent safety profile. So I think for my practice, I'm not ready to do that adaptive approach yet.
Well said. So certainly a lot of potential, but we're not quite yet there. And
Exactly.
So following the trial design as it was carried out is the prudent approach.
It could be our future. I don't know if it's our current present. And I think it's a very doable regimen. And I think we're able to achieve the efficacy. Ultimately, we all want great outcomes for our patients. We want to try and figure out who we could spare more for, but not at compromising what we currently can achieve.
Absolutely, especially for a high-risk population,
Absolutely.
as you pointed out.